Good morning to everyone. RADS Mammography and Ultrasound 2013. The RADS is a risk assessment and quality assurance tool developed by American College of Radiology that provide a widely accepted lexicon and reporting schema for breast imaging. The ASR RADS 2013 is an updated version of RADS 2003. RADS is designed to standardize breast imaging reporting to reduce confusion in breast imaging interpretation. It also facilitates outcome monitoring and quality assessment. Contain a lexicon for standardized terminology for mammography, breast ultrasound, and MRI. The standard reporting consists of describe the indication for the study, whether screening, diagnostic, or follow-up. Mention the patient history. If the ultrasound is performed, mention if the ultrasound is targeted to a specific location or supplementary screening. Describe the breast composition. Describe any significant finding using a standardized terminology. Use the morphological descriptors such as mass, asymmetry, architectural distortion, and calcification. These findings may have associated features like, for instance, the mass can be accompanied with the skin thickening, nipple retraction, and calcification. Correlate these findings with the clinical information, mammography, ultrasound, or MRI. Integrate mammography and ultrasound finding in a single report. Compared to a previous study, awaiting a previous examination for comparison should only take place if they are required to make a final assessment. Conclude to a final assessment category. Use RADS category 0 to 6 and the phrase associated with them. If mammography and ultrasound are performed, overall assessment should be based on most abnormal of the two breasts, based on a highest likelihood of malignancy. Give the management recommendation and communicate an expected finding with referring clinician. As I said, the standard reporting consists of indication, a breast composition, important finding, comparison to previous study, final assessment category, and give management recommendation and communicate unsuspected finding with the referring clinician. First, describe the breast composition. The ultrasound lexicon has many similarity to mammography lexicon, but there are some descriptors that are specific for the ultrasound. The table is showing both mammographic lexicon and ultrasound lexicon. I will discuss them in more details. This is the table showing the final assessment category. Give the category and given the typical management for them, and then the likelihood of the cancer for each category. First of all, we describe the breast composition. In RADS edition 2003, the assignment of a breast composition was based on the overall density resulting in category 1, less than 25% of fibroglandular tissue, category 2, between 25 to 50%, category 3, 50 to 75%, and category 4, more than 75%. In RADS 2013, the use of percentage is discouraged because in individual cases, it's more important to take into account the chance that the mass can be obscured by fibroglandular tissue than the percentage of a breast density as an indicator for breast cancer risk. So that the RADS edition 2013, the assignment of a breast composition is changed into A, B, C, D category. The A is the breast is almost entirely fatty. Mammography is highly sensitive in this setting. B is there is a scattered area of fibroglandular density. C is the heterogeneously dense, which may obscure the small masses, and D is extremely dense, which lower the sensitivity of mammography. As we are seeing in this mammogram, the right mammogram describes the breast composition according to RADS 2003, while the left one describes the breast composition according to RADS 2013, which divided the breast composition into 4 categories, A, B, C, and D. Notice in the left, in the left example, the composition is C, heterogeneously dense, although the volume of fibroglandular tissue is less than 50%. Fibroglandular tissue in the upper part is sufficiently dense to obscure small masses, so it's called C. Because the small masses can be obscured, this is what has been called the ASR2. Give the breast density 25 to 50%, while the example on the right is more than 50% fibroglandular tissue, but also called composition C according to RADS 2013. The mass. The mass is a space occupying a three-dimensional region seen in two different projections. If a potential mass is seen in only a single projection, it should be called asymmetry until its three-dimensionality is confirmed. So when we detect the mass, we should define the shape of the mass, the margin, and the density. As we are seeing in this mammogram, the image shows fat-containing lesion with the popcorn-like calcification. All fat-containing lesions are typically benign. These image findings are diagnostic for hamartoma, also called fibroadenolipoma. The shape of the mass is either rounded, oval, or irregular. Always make sure that the mass that's found on physical examination is the same as the mass that's found on mammography or ultrasound. Location and the size should be applied in any lesion that must undergo biopsy. The margin of the lesion, either circumscribed or well-defined, this is benign, or obscured or partially obscured when the margin is hidden by superimposition of fibroglandular tissue. The ultrasound can be helpful to define the margin better. Microlobulated is suspicious finding, indistinct or ill-defined is also another suspicious finding, and speculated margin is very highly suspicious finding. The density of the mass related to the expected attenuation of an equal volume of fibroglandular tissue. High density associated with malignancy, extremely rare for the breast cancer to be low density. Here we have multiple circumscribed low density masses in the right breast, the result from lipofilling with the transplantation of body fat into the breast. Here, hyperdense mass with irregular shape and speculated margin with focal skin retraction. This was reported as PIRAT5 and proved to be invasive ductal carcinoma. Architectural distortion. The term architectural distortion is used when the normal architecture is distorted with no definite mass visible. This includes the thin straight line or speculation radiating from a point and focal retraction, distortion, or straightening at the edge of parenchyma. The differential diagnosis, either the scar tissue or carcinoma. The architectural distortion can also be seen as an associated feature. For instances, the mass that causes architectural distortion, the likelihood of malignancy is greater than in case of the mass without distortion. This mammogram showing the distortion of normal breast architecture on both oblique view and magnification view. A resection was performed and only scar tissue was found in the specimen. Asymmetries, the finding that represent unilateral deposits of fibroglandular tissue not conforming to the definition of the mass. Asymmetry as an area of fibroglandular tissue visible in only one mammographic projection, mostly caused by superimposition of normal breast tissue. The focal asymmetry visible in two projections. Hence, a real finding rather than superimposition. This has to be differentiated from a mass, while the global asymmetry consisting of asymmetry over at least 1/4 of a breast and is usually a normal variant, while developing asymmetry in new, larger, and more conspicuous than a previous examination. Here, an example of focal asymmetry seen on mediolateral and craniocaudal view. The local compression view and ultrasound didn't show any mass. While here, the global asymmetry with other associated malignant features like skin thickening, thickened septa, and subtle nipple retraction, PET-CT show diffuse infiltrating carcinoma. How to differentiate asymmetry from the mass? All types of asymmetry have different border contour than true masses and also the lack of the conspicuity of the mass. Asymmetries appear similar to the other discrete area of fibroglandular tissue, except that they are unilateral with no mirror image correlate the opposite breast. Asymmetry demonstrates concave outward border and usually interspersed with fat, whereas the mass demonstrates convex outward border and appear denser in the center than at the periphery. Now we have calcification. In 2000, the three calcifications were classified by morphology and distribution as either benign, intermediate, or a high probability of malignancy, while in 2013 version, the approach has changed. Since the calcification, both intermediate and the high probability, it have the same management, so that the calcification was changed into typically benign or suspicious morphology. Within this last group, the chance of malignancy are differentiated depending on their morphology, either by RADS 4B or 4C, also depending on their distribution. The calcification, which are typically benign, are the skin, vascular, coarse, large, rod-like, round or punctate less than 1 mm, rim dystrophic, milk of calcium, and sutural calcification are typically benign. There is one exception of the rule. Isolated group of punctate calcification that's new, increasing, linear or segmental in distribution, or adjacent to a non-cancer can be assigned as probably benign or suspicious. Suspicious morphology are amorphous, which given by RAD4B, so small and or hazy in appearance that are non-specific particle shape cannot be determined. Coarse heterogeneous by RAD4B also irregular conspicuous calcification that are generally between half to 1 millimeter and tending to coalesce but are smaller than dystrophic calcification. Fine pleomorphic given 4C usually more conspicuous than amorphous form and are seen to have discrete shape without fine linear and linear branching form less than half millimeter. Fine linear or fine linear branching given also 4C by RAD4C, thin linear irregular calcification may be discontinuous. Occasionally branching forms can be seen usually less than half millimeter. The distribution of calcification, the arrangement of calcification distribution is at least as important as morphology. This includes diffuse, distributed randomly throughout the breast, regional occupying a large portion of a breast tissue more than 2 cm, while grouped or clustered, a few calcification occupying a small portion of a breast tissue, lower limit 5 calcification within 1 cm, and the upper limit are larger number of calcification within 2 cm. Or segmental suggests linear arranged in a line which suggests deposits in a duct. Segmental suggests deposits in a duct or duct and their branch. In 2013 edition, refined the upper limit size in group distribution as 2 cm while retaining more than 2 cm as a lower limit for regional distribution. Here we are seeing the mammogram showing the coarse heterogeneous and some look more like fine pleomorphic calcification distribution. Some are arranged in a group less than 2 cm and another arranged as regional distribution more than 2 cm, proved to be multifocal ductal carcinoma in situ with area of invasive carcinoma. Associated feature are things that are seen in association with suspicious findings like mass asymmetries and calcification. Associated feature play a role in a final assessment. For instances, BI-RAD4 mass get BI-RAD5 assessment if associated with skin retraction. The location in mammography and ultrasound. A mass is seen in this figure in the outer lower quadrant of the left breast at 4 o'clock in the posterior portion of the breast at 4 cm distance from the nipple. So the complete set must be mentioned as consists of designation of right and left quadrant and the clock face notation. On ultrasound, the quarter and the clock face notation should be supplemented on the image by means of body marker and transducer position, the depth, anterior middle and posterior third distance from the nipple. The size measurement in mass, the longest axis of the lesion and the second measurement at right angle. And speculated mass speculation should not be included. Architectural distortion and asymmetry, approximation of its greatest linear dimension. Calcification distribution should be measured by approximation of its greatest linear dimension. Lymph node within mammography by taking the short axis and ultrasound by taking the cortical thickness. Now we have the ultrasound breast imaging lexicon. Many descriptors for the breast are the same as for mammography, but there are special things that are specific or specific terms specific for the ultrasound. The breast composition in the ultrasound is homogeneous ecotexture fatty or homogeneous ecotexture fibroglandular tissue or heterogeneous ecotexture. The mass in the ultrasound, it have a specific feature to be mentioned, such as orientation, is unique to the ultrasound imaging and defined as either parallel, which is benign, or antiparallel, which is malignant. The echo pattern as anechoic, hypoechoic, complex, cystic, and solid, and etc. Echogenicity can contribute to the assessment of the lesion together with the other finding category. Alone, it has a little specificity. Posterior features such as enhancement and the shadowing, it is also represent the attenuation characteristic of the mass with respect to its acoustic transmission. Also of additional value, alone it has little specificity. The calcification within the ultrasound, on ultrasound poorly characterized compared with mammography, but can be recognized as echogenic foci, especially within the mass. Associated features like architectural distortion, duct changes, skin changes, edema, vascularity, and elasticity assessment. There is something or special cases that are pathognomonic on have pathognomonic ultrasound appearance, such as simple cyst, complicated cyst, clustered microcyst, and masses in or on skin, foreign body, lymph node, intramammary or axillary, vascular abnormality, post-surgical fluid collection, and fat necrosis. Now we have the final assessment category. BI-RADS 0 need additional imaging evaluation and or prior mammogram for comparison. BI-RADS 0 is utilized when further imaging evaluation or retrieval of prior examination is required. When additional imaging studies are completed, a final assessment is made. Always try to avoid this category by immediately doing additional imaging or retrieving the old found before reporting. Even better to have the old examination before starting the examination. This patient present with the mass on mammogram at screening, which was designed as BI-RADS 0. Additional ultrasound examination of the mass was caused, detect that the mass caused by intramammary lymph node, and given the final assessment is BI-RADS 2 as the benign finding. Don't mention in the report that the lymph node on the ultrasound correspond with non-calcified mass seen on mammography. When to use the BI-RADS 0? Use if additional mammographic imaging is needed. Use if additional ultrasound or mammography is needed. Use of prior mammography or ultrasound are required to make a final assessment. Don't use if prior mammography or ultrasound are not available. And don't use if prior mammography or ultrasound are irrelevant. And don't use for finding that warrant for the evaluation with MRI, but make a report before the MRI is performed. BI-RADS 1 is negative. There is nothing to comment on. The breasts are symmetric, no masses or architectural distortion or suspicious finding. The BI-RADS 1, there is nothing to comment on. So use it when there is no any abnormal imaging finding in a patient. And if there is palpable abnormality, possible a palpable cancer, but at the sentences recommending surgical consultation or tissue diagnosis if clinically indicated. BI-RADS 2, benign finding like BI-RADS 1. This is a normal assessment. The interpreter chooses to describe the benign finding in the report. This category is applied to follow-up after breast conservative surgery, involuting calcified fibroadenoma, multiple large rod-like calcification, intramammary lymph node, vascular calcification, implant, architectural distortion clearly related to prior surgery, fat-containing lesions such as oil cyst, lipoma, galactosile, mixed density hamartoma. They all have characteristically benign appearance and may be labeled with confidence. When to be used BI-RADS 2? Use in screening or in diagnostic imaging. Use in the presence of bilateral lymphadenopathy, probably reactive or infectious. Use in diagnostic imaging and recommend management if appropriate, such as abscess or hematoma, and as implant rupture or other foreign body. Don't use when a benign finding is present but not described in the report. Then use category 1. Don't recommend MRI to further evaluate a benign finding. BI-RADS 3, a probably benign finding, initial short interval follow-up is suggested. The finding placed in this category should have less than 2% risk of malignancy. It's not expected to change over the follow-up interval, but the radiologist would prefer to establish its stability. So that the lesion is placed in this category is non-calcified circumscribed mass on baseline mammogram, unless it's a cyst or intramammary lymph node or other benign finding, focal asymmetry which become less dense on spot compression view, and solitary group of punctate calcification. Here, a non-palpable, sharply defined mass with a group of punctate calcification. This categorized as BI-RADS 3. Continue follow-up image change to category 2 after follow-up. Initial short-term follow-up of BI-RADS 3 lesion is unilateral mammogram at 6 months, then bilateral follow-up examination at 12 months. Assuming stability, perform a follow-up after 1 year and optionally another after another year. If findings show no change in follow-up, the final assessment is changed to BI-RADS 2 as benign and no further follow-up is needed. Follow-up at 6, 12, and 24 months showed no change and the final assessment will change into category 2. Nevertheless, the patient and the clinician preferred removal because the radiologist was not able to present a clear differential diagnosis, so added the BI-RADS 2 finding, but instead of stopping follow-up, the tissue diagnosis was performed due to the patient and referring clinician concern. If BIRAD 3 lesion show any change during the follow-up, it was changed to BIRAD 4 or 5, and the biopsy should be performed. The image show a few amorphous calcification, as we are seeing in this mammogram, initially classified as BIRAD 3. At 12-month follow-up, more than 5 calcifications were noted in a group. So the findings were changed into the BIRAD 4, and this is proved to be ductal carcinoma in situ with invasive carcinoma. When to use BIRAD 3? Use the BIRAD 3, do perform initial short-term follow-up and after 6 months, and as I said, assuming stability, perform second short-up bilateral mammogram at another 6 months, and after stability, another mammogram doing after 1 year and optionally after another year. Do realize that a benign evaluation may always be rendered before completion of the category 3 analysis if, in the opinion of radiologists, the finding has no chance of malignancy and thus it is category 2. Use when there is the finding on mammography that are like non-calcified circumscribed solid mass, focal asymmetry, solitary group of punctate calcification, use in finding on ultrasound which suggests typical fibroadenoma, isolated complicated cyst, and clustered microcyst, and use in a probably benign finding while the patient or referring clinician still prefer the biopsy. Don't use if unsure whether to render a benign category 2 or suspicious category 4. So then use category 4. Don't use in screening examination. Don't use in diagnostic examination if additional imaging is required. Don't use if a lesion previously assessed as category 3 has increasing in size or extent, like a mass on ultrasound with increase in 20% or more of longest dimension. Then use category 4. Don't recommend MRI to further evaluate a probably benign finding. BIRAD 4, suspicious abnormality biopsy should be considered. This category is reserved for findings that don't have the classic appearance of malignancy but are still sufficiently suspicious as to justify a recommendation for biopsy. It has the wide range of probability of malignancy between 2 to 95, subdividing the category 4 into A, B, C. It's encouraged that relevant probability for malignancy be indicated within this category so the patient and her physician can make an informed decision on ultimate course of action. So, do use for finding sufficiently suspicious to justify biopsy. And do use category 4A in finding as partially circumscribed mass suggestive of atypical fibroadenoma, palpable solitary complex cystic and solid cyst, and a probable abscess. And use category 4B in finding as a group amorphous or fine pleomorphic calcification, nondescript solid mass with indistinct margin. 4C are used in finding such as a new group of fine linear calcification, a new indistinct irregular solitary mass. Here, the craniocaudal mammographic image show a finding not reproducible on mediolateral view. This finding is sufficiently suspicious to justify biopsy. Benign lesion can be the possibility, but for instances, maybe ectopic fibroglandular tissue within a heterogeneously dense breast. This lesion is given category BIRAD 4. Another BIRAD 4 abnormality, the pathologists diagnose them as either sclerosing adenosis or ductal carcinoma in situ. Both diagnoses are concordant with mammographic finding. BIRAD 5, highly suggestive of malignancy. Appropriate action should be taken. BIRAD 5 must be reserved for findings that are classical for breast cancer, and the likelihood is more than 95%. The current rationale using category 5 is that if the percutaneous tissue diagnosis is non-malignant, this is automatically should be considered as discordant. The finding that given the BIRAD 5 is the speculated irregular highly density mass, segmental or linear arrangement of fine linear calcification, irregular speculated mass with associated pleomorphic calcification. As we are seeing in this mammogram, the characteristic appearance of malignancy, the mass with irregular shape, speculated margin, high density, the ultrasound show irregular shape with indistinct margin, so it's given BIRAD 5. BIRAD 5 is given when there is combination of highly suspicious finding, like speculated irregular mass, high density, fine linear calcification with segmental or linear arrangement, irregular speculated mass associated pleomorphic calcification, used in finding in which any non-malignant percutaneous tissue diagnosis is automatically considered discordant between the imaging and pathology. Use in finding sufficiently suspicious to justify category 5, and the patient or referring clinician refrain from the biopsy because contraindication or other concern. And don't use if only when highly suspicious findings are present, then use category 4C. RADS 6. Use when after incomplete excision or after monitoring response to new adjuvant chemotherapy. Don't use after attempt surgical excision with positive margin and no imaging finding other than post-surgical scanning. Then use category 2 and added the sentences stating the absence of mammographic correlate for pathology. Don't use for imaging finding demonstrating suspicious finding other than the non-cancer. Then use the category 4 or 5. Here the image of a biopsy-proved malignancy on initial mammogram. The mass cannot be seen because of dense fibroglandular tissue. On ultrasound, demonstrate 37 millimeter mass with indistinct and angular margin and shadowing. After chemotherapy, the tumor is not visible on mammogram, so that the ultrasound shows the shrinkage of a tumor to 18 millimeter, so that we categorize as RADS 6. When we use more modality, always make sure that we are dealing with the same lesion. For instances, the lesion found on ultrasound doesn't have to be as the same as the lesion seen within the mammogram or physical examination. So we should repeat the mammography with marker on the lesion found on ultrasound can be helpful. The cyst can be aspirated or filled with air after aspiration to make sure that the lesion found on mammogram is caused by the cyst. Solid lesion can be injected with the contrast to help in difficult cases. Here the image of the patient with a new lesion found on mammography at screening. Ultrasound detects the intramammary lymph node, but we are not sure whether this lymph node is the same lesion seen on mammography. So we inject the lesion with contrast and repeated the mammography so that we are sure about this lymph node or intramammary lymph node seen on ultrasound is the same lesion seen on mammography. This patient present with the tumor on the left breast. In the right breast, a group of amorphous and fine pleomorphic calcification was seen, so the ultrasound examination was performed. Ultrasound of the region demonstrates an irregular mass with proved to be adenocarcinoma by FNA. To find out whether the mass within the area of calcification, contrast was injected into the mass. The mass is evidently in another region of the breast, so that we doing vacuum-assisted biopsy has to perform for calcification, because maybe dealing with the ductal carcinoma in situ in one area and invasive carcinoma in another area. So the contrast is so helpful. As I said, the typical reporting is most include describe the indication of a study, describe the breast convulsion, describe any significant finding using standardized terminology, and compare to a previous study, conclude the final assessment category, and give the management recommendation, and also communicate unsuspected finding with the referring clinician. And this is example of reporting. The mammography showing overall breast composition is B with scattered area of fibroglandular density, lateral in the right breast concordant with the palpable lump. There is a mass which is oval in shape, and the margin partially circumscribed and partially obscured. The mass is equally dense compared to fibroglandular tissue. The location in the right breast, 9 o'clock position, middle third of the breast, and the size is approximately 3 cm. And additional ultrasound of the mass concordant with the lump and the mass on mammogram. There is the oval simple cyst parallel orientation, circumscribed anechoic with posterior enhancement. The size 3.5 with 1.5 cm, and the right breast at least 2 more smaller cysts, so that the assessment is BIRAD 2 benign finding with a palpable mass is a benign cyst with at least another small 2 cysts. The management will, if it is painful, so that it's concerned about communicating with her physician. Another typical reporting showing the mammography overall breast convulsion is the breast is almost entirely fatty, lateral in the left breast at 3 o'clock. There is 3 o'clock position in posterior third of the breast. There is the lump that are concordant with palpable lump that is a 3 cm hyperdense mass with rounded but also irregular shape. the margin partially circumscribed and partially not circumscribed, and the ultrasound is concordant with the lump and the mass that are seen on mammogram, which are slightly irregular hypoequivoc mass with non-parallel orientation, so that it's given BI-RADS 4A with low suspicious for malignancy, and it is given the differential diagnosis either atypical fibroadenoma or phylloids. And the 14-gauge core needle biopsy was performed without any complication. And thank you.
عاش أكيدك دكتورة صابرين جبار.